Dr. Hazra, please.
Good morning, Lucknow. Friends, today's talk is on HPR in coronary interventions. Coronary artery disease, like a pimple on your face, you may heal one, but another one pops up, and you fix this by a stent, and when you put a stent, the stent heals. But it has got some issues in other sides, like you have CAD, PAD, and stroke, and you can reduce the stroke, death, MI in other coronary bed by using DAPT statin, SGLT2, GLP-1, inclisiran, PCSK9, bempedoic, and so on and so forth. But sometimes it comes as a surprise, as a collateral damage, as a bleeding. And we know that the bleeding can scare your patient, yourself, whole staff, the whole hospital, the patient relative. And out of all these, I can put in hierarchy. This is my assumption. And if I have a patient bleeding from the gut, bleeding from an ulcer or tumor from the gut, that is the most scaring thing in PCI. Next will be thrombocytopenia. Many of these patients will have oral anticoagulant on board, whether in NOAC or other forms of walk, frail patients, but I will put some points. If you have more points, you have more risk in these patients. So how do you fix the fixable fixing first? Like if you have hypertension, control your hypertension. If you have atrial fibrillation, if it's a candidate for LA closure, do the LA closure, obviate the need for warfarin, and LA closure will obviate the need for a NOAC. If you do have PPI, you treat the ulcer, you treat the prostate by prostate angioplasty, stop the bleeding from your prostate, or you do the laser of the gut, laser of your bladder, anticipated low-risk surgery complete, then you proceed for the angioplasty, build up hemoglobin, stop NSAID, varicose embolization tips, and other things you can fix. So this is LA closure. This is very nice. Now, if you have a choice for femoral and radial, you can go from left to right, and always use a micropuncture needle for your femoral axis and stop using the larger sheath. So have a very high threshold for larger sheath and low threshold for radial left, right snap box and closure device. Cheap cases are not the usual cases or the ideal cases for doing in HBR patients, so try to avoid using Impella or ECMO kind of things in in HBR patients. Try to bring the new technology of assessing these lesions and try to avoid stents as far as possible, if it is possible, or reduce the length and number of the stent using FFR of all types, FFR, QFR, DFR, etc. And most of these stents have been tried in HBR with the giant stent, because the giant stent came early, the same platform, metal and the polymer still there. So ruling the roost is in Giants in Canada, then the Synergy, one of the best stent, and Onyx. These are the three stents I prefer in HBR patients. Now the stents are not born equal. They are born differently with their stent start thickness, their width. For example, the Promus, Giants, Prime, Alpine, and Synergy is 81 micron, but if you go to 3.5 Synergy, it comes down to 79 micron, and if you ever mind that 50 micron is the stent size. The stents are different, and if you put the thinner stent, the chance of having early endotheliation is rapid. The long-term MACE will be definitely less, and also Synergy have got least stent width. So choose your best stent, and you should know the genre. For example, choosing 3.5 millimeter Synergy of 79 micron for a 4 millimeter vessels, it will be ideal choice rather than using 4 millimeter Synergy of 81 micron for 4 millimeter vessels, because you can make 3.5 to 4.5 millimeter. Now, in this Twilight trial, 3 months adapt, all these are the stents which has been tried, which includes BPDS and DPDS. Many of these stents which are not available in India, but they have been tried. So whole gamut of stents are quite safe in this group of people. So imaging and simple technique, crossover, bivalodine, argatrobat is my choice. I do not use heparin in this patient for last 5 years. And sometimes you can land up with trouble like this. If you have a patient whom you have done the right coronary angioplasty, you have produced some perforation and dissections. And what do you do? In our practice, we can stop aspirin, but the aspirin will be there for some time. If you send this patient for surgery, surgery will be definitely a problem. But now we have a solution that, like, if you dialyze this patient, you remove your urea creatine potassium. If you dialyze this septicemic patient, you can remove 99% of your bacteria from the system. If you have a ticagrelor on board, if you remove this by your CPB absorb filter, you can remove almost 99% of ticagrelor on board within 30 minutes. So your bleeding risk actually comes down significantly. This has been tried in 40 patients in Germany. The need for platelet transfusions, the need for reopening the chest, it come down by almost 95%. The need for blood transfusion has come down by 95%, and if you feel safe. Now, go solo with the monotherapy. You can go solo with the aspirin. You go solo with ticagrelor. The Japan, they do not have ticagrelor so far in last 20 years. They use small dose of prasugrel. But in India, we can use either of them. You can go solo at 3 months. You can go solo at 4 months. And there are more data evolving for no therapy, like zero DAPT after 1 month. Now, this is the story of the stent thrombosis, and we have progressed because of many trial and also personalities like Colombo, when he started doing post-dilatation in many of these patients. So this is the evolution of therapy in PCI, and we have evolved a lot, and we have removed, we have done a historical mistake having BMS 4 weeks antiplatelet therapy, then horrible taxes and Cypher stent. Those stents are not there. Again, these mistakes are corrected by newer design, newer type of your polymer and start thickness. Now, if you talk about HBR, and they are vary from trial to trial. You have many criteria, around 12 to 20, minor and major. The most of these trials, they take this age as one of the best criteria or ideal criteria, and majority of patients. Then comes OAC, CKD, liver disease, cancer, anemia, low platelets, history of stroke, actionable bleed, hospitalized bleed, NSAID, etc. Now, out of these, I will tell you the master DAP trial, where the Ultimaster Tansai and Ultimaster has been tried. They have included many of these criteria into consideration. This is one of the best trials. Now, target safe, this is a huge trial of Chinese stent. Even they have persuaded the American people of Martin Leon to conduct these trials with FireOx stent. They have included separate things for HBR, which is different from ASHB criteria like BMI. They have included female patients, ACS, ulcer, and has-bleed score also. So we have this Giants trial, Twilight HBR trial, which has been published recently, and Evolve Short, Poem trial is Synergy, and they have some like issues like single arm trial is not a randomized trial, and some has taken different considerations. Now this is male and female, maybe from different starts, but they do behave differently because of body surface area, be it ejection fraction, be responsive to your therapy or sudden cardiac death and bleeding also. In Asians, the females, they suffer most. Now, all these trials they are talking about the MACE, and MACE means major adverse cardiac event, or extended MACE, like you have other things like bleeding, and they put the things in the hierarchical manner. You have a different design, non-inferiority, superiority. So what are the losing trials, like Stop DAP to ACS in 2021, again a loser. You have globally, this is a loser. Most of the trials are winner in terms of NACE or non-inferiority. Some of these trials are superior, some of the trials are non-inferior, and some of these trials are non-inferior. Now, we are moving towards newer era of assessing the MACE, like we do not believe that death, MI, stroke should be the future design or composite endpoints, because there are so much issues with the MI definitions, and you can win by just MI, not reducing death, or you can win by stroke. Sometimes the death is the best thing, but sometimes it reduces the power of the trial, increases the size and the number and the duration. So that's why people do not want to invest only in death. Sorry for the spelling mistake. And nowadays in the HBR, we're moving towards the NACE. Now, the DAPT, again, as I said, there are no DAPT like ACET Japan, Stop DAP3, ICER with Prasugrel only, Optica, STEMI, Zero DAPT, Neomind, so the new trials will be available in 2023. Only 1 month trials are enlisted here, up to 3 months enlisted here, up to 4 months enlisted here, up to 6 months enlisted here, Themis and Pegasus. Now, this Pegasus trial actually is a kind of red herring, taking our patients for almost a lifelong DAPT, because we had that bad memory, bad legacy, and bad stent, and historical mistake of Cypher and Taxa stent, and your bare metal stent. Now, a master DAP trial, there is a winner and a loser. Terumo BP is the winner, clopidogrel SAPT is the winner, abbreviated DAPT is the winner in STEMI and ACS, even just 1 month DAPT, then is SAPT, whole concept of short DAPT is the winner in master DAP. You gain 18 strokes, 7 ischemic, 3 hemorrhagic at the cost of 16 MI and 610 thrombosis on abbreviated DAPT. The tragedy may be clopidogrel or ASA monotherapy because Asians and Indians, they do not have that much responsiveness, and some people are clopidogrel resistant. So anyway, you gain 53 bar bleeding, and you know these trials are moving in a better design, and you master DAP trial has told us that if you select your patient correctly and give your medicine correctly, you can prevent her death, MI in stroke as a composite even after shortening your course of your antiplatelet. You have to prolong the DAPT, or if you have atrial fibrillations or who are candidate for WAC or warfarin, even then, if you start at 6 months, you go solo with aspirin or your ticagrelor or clopidogrel, and after 12 months, if you continue with just WAC, you can prevent many bleeding, you can prevent death, MI, as good as continuations of your DAPT normal sinus rhythm. So primary outcome in the non-inferiority has been proved, non-inferiority for major adverse cardiac event has been proved, and superiority on the bleeding has been proved by the master DAPT trial with a significant p-value. So winner in twilight is the many DS. You have to have a perfect landing on the stent by using imaging. The difference between active control trial, randomized control trial, these are the two highlights of master DAPT in twilight HBR in 2021. And this first trial, which has included many Indian patients in master DAP. And as I mentioned, that we are moving towards the freedom of a choice. You have Coca-Cola, but you can go for a Pepsi. And the best choice will be a best stent, and the best DAPT so far in the high bleeding risk is clopidogrel. There are more evidence on clopidogrel, but those who are preferring ticagrelor, they can go solo with the ticagrelor. After some time, they can go solo with the best stent with the aspirin. And sometimes you need to manage your other parameters. As I mentioned, you fix the fixable first, or you can go for a LA closer in some of the people who needs it. How I know that I have done enough, as Dr. Vivek Kumar elegantly has mentioned, that there is some style of doing angioplasty in modern days. Avoid too many stents, avoid doing complex angioplasty in HBR. And I said it before, the imaging is important, DAPT to SAPT is important. Good medical therapy is alternative to many coronary artery disease after ischemia trial, rather than bombarding this coronary bed with too many stents and too many things. With that, I would like to thank you for your kind attention. Thank you very much.
And certainly the newer stents, they have come, and studies have come that you can shorten the DAPT. In clinical practice, for example, if you have a ACS patient with very low platelets and you want to go for early intervention, so what?
In HBR?
In HBR.
HBR, as I mentioned, that even in STEMI and ACS from master DAP trial, we have to choose the best stent. And the evidence-based stent, you have Ultimaster Tensai. Only 15 has Ultimaster Tensai, but most of the stents were, rest was Ultimaster, Onyx. I'm not.
No, Dr. Hazra, to begin with, if the platelet count is very low, for 40,000, 50,000.
Platelet count is very low. So,
yes.
okay, if the platelet count is very low, I would advise that you try to believe the ischemia trial. And if you can manage on medical therapy, you please manage with the medical therapy. But if he has got ST elevation MI, even in spite of having low platelet, or he is having a very high risk ACS, you have to go forward with your angioplasty and do the routine angioplasty. Try to be on even single antiplatelet, just like clopidogrel monotherapy or ticagrelor you can use. Try to avoid heparin. I go for argotraven, sometimes cangrelor on the board. Then I switch to clopidogrel. So you have to assess the patient as the risk is assessed by you.
Yes.
So every patient is different, one size does not fit all.
I'm sorry for the interruption.
Yeah, and what is your say on the polymer-free stents?
Okay, so polymer-free stent, there are many trials for polymer-free stents, but I would say that polymer actually heals your endothelium. Like Giant's polymer is more antithrombotic than you have a bare metal stent or polymer-free stents.
I'm sorry for the interruption, Mr. Chairman.
Thank you, Dr. Hazra.
Thank you very much.
Thank you, Doctor.
I want to